right, well again, welcome tonight. Hopefully you all can hear me. I'm going to talk a little bit about robotic joint replacement. First off, wanted to introduce myself. I was born at St. Luke's, so my standard joke is that we accept all kinds at St. Alphonsus. I graduated from Bora High School. We used to be really good at football. I went to medical school at the University of Washington. And then I did a fellowship at the Hospital for Special Surgery, which is affiliated with Cornell in New York City. And there I studied joint replacement and reconstruction, ranging from robotics to revision joint replacement, all on the hip and knee was my area of focus. And Hospital for Special Surgery has been a highly ranked institution for a lot of years, and so I got a chance to study with some of the real pioneers of joint replacement. We have a long tradition in my family of orthopedics. There's my dad and my brother, both orthopedic surgeons here in the Valley. Another brother, not in that picture, is an orthopedic surgeon down in Arizona. And then these guys on the wall are all Idaho physicians, starting with my great-great-grandfather in kind of the Preston, Idaho area, my great-grandfather, then my grandfather, who was an orthopedic surgeon here in Boise at St. Alphonsus, and then my dad gets to be twice, except he looks a little different in these two pictures, which I point out to him all the time. These are my kids, Audrey and Cutler, and maybe one of them will choose to follow in our footsteps, or they might do something totally different. So movement is critical to life. It allows us to get from place to place, take care of ourselves, engage with our friends and family, and be out in the community. And when our hip and knee becomes injured, pain can limit our ability to do that. It can limit our ability to walk and to move about in our environment. Arthritis has a specific meaning in orthopedics, and it's damage to cartilage. We'll go over that a little bit more. There's about 100 different kinds of arthritis. The most common is osteoarthritis or wear and tear arthritis. Rheumatoid arthritis is another common form of arthritis. That's an inflammatory type of arthritis, where the body gets a little confused and attacks its own cartilage. There's post-traumatic arthritis, which is arthritis resulting from an injury, either a fracture or another kind of injury. And although it's mainly an adult disease, arthritis can affect the very young, even children. When it comes to arthritis, you're not alone. There's a lot of people, 21 million, and now I've seen an estimate up to 30 million Americans every year have some form of disability because of arthritis. So what exactly is it? So this is the picture of a hip joint, and this blue represents the cartilage. If you think about a chicken bone and you open up a chicken bone, on each side of a joint where two bones are touching, there's the gristle or the white part. That's the cartilage. It's a couple millimeters thick. And so each part of our joints, both in the hip and the knee, have a couple millimeter layer thick of cartilage on each side, and that allows the joint to move smoothly. As we wear that cartilage out, you get bone spurs, you get bone rubbing on bone, you get thickened soft tissue around the joint, and all of that can cause stiffness and pain. And so that's what arthritis is. It's that wear or loss of cartilage. Here is an example on an x-ray. We talk about the joint space. So that's the space between the two bones. You see the round ball of the femur and then the socket side of the pelvis. That's the normal joint space. It's not really a space. It's full of that thick rubbery material, that cartilage. When we get arthritis, that space totally goes away, and you can see there's that bone-on-bone arthritis. This is severe arthritis. In response to the joint space narrowing, we also get bone spurs. The knee's very similar, so the knee's coated in cartilage, just like any joint is. In between the knee are a couple bumper pads called meniscus. When that cartilage wears away, which can happen because of meniscus damage or other reasons, we get this area of wear, and that causes, again, pain. You can see an example. Here's where the wear is mostly on the inside part of the knee. So here's a normal joint space, not really a space, full of cartilage. And then there's the inside part of the knee where, having taken away that joint space, you get that bone-on-bone arthritis. So here's the bad news of tonight's talk, is there's not a cure for arthritis. There's not a fix for arthritis. There's ways that we can live better with arthritis, and we'll talk about those things. Many, many treatment options. And they're designed to manage pain, to help improve pain, decrease pain. help keep you active, help keep you doing the things you love to do. So non-surgical, we'll talk about that first. We should always start with non-surgical. Lifestyle modifications, that's kind of if you keep hitting your thumb with a hammer and it hurts, stop hitting your thumb with a hammer. So there's certain activities that you can modify. Lower impact activities are going to be more nice to your joints than high impact activities. So substitute cycling from running, that kind of stuff. Minimize those activities that you know cause pain. If you know something always hurts and you're able to avoid it, avoid it. And again, switching from those higher impact activities to the lower impact activities. Losing weight can make a big difference. Even small weight loss can make a big difference, both in the knee and in the hip. That's because the body sees about 4 to 5 times body weight in the joint. So if you lose a pound, you lose 4 pounds of force out of the joint. That's because we have to fight gravity as well as the force that our muscle generates for us to not fall over when we're walking. And so carry extra 5 pounds in your purse or your backpack, you're carrying really 4 times that, 5 times that, so 20 pounds, and it can make a big difference. So even a 5 or 10 pound weight loss can make a big difference too. Using physical therapy as a way to increase range of motion, which is really important. Strength, which is really important, and flexibility. Range of motion and strength improve with physical therapy and time. So you can't just go to one session and get the benefit. You have to go to therapy and then do the home exercise program for weeks before you really start to see the benefit. And sometimes that increases a little bit of the soreness in the knee. But eventually, as the muscles get stronger, as the range of motion improves, the muscles then can act as a shock absorber, and that can help a lot with pain. Therapy can be really helpful because the therapist can look at you and individualize the type of exercises that are going to help, as well as look at you and the way that you walk and give you personalized feedback on your own home exercises that you do. Assist devices are really important. These are things like canes, inserts in your shoes, a hiking stick, wearing a brace or a knee sleeve. And those are basically, if it helps, if it feels better, it's a good thing. Hiking sticks are these guys, these trekking poles you see people using. People are more apt to use them than a cane. They don't have the same kind of stigma as it is with canes and that sort of thing. And canes operate on that same principle. Hiking sticks operate on that same principle of 4 to 5 times body weight. So if you can get a little bit of force out of your knee into the sticks through your arms, 10 or 20 pounds, again, multiply that by 4, that's the amount of force that's coming out of your knee or your hip. Excuse me. Other remedies, heat and ice. Ice is one of the biggest ones. I've found that most people like an alternative heat and ice on their muscles, so up in the thigh or down in the calf where the pain can radiate. But then on the joint itself, ice seems to work really well. You can use the ice machines or just cold packs. I recommend that we ice our knees up before we go to sleep at night if they're hurting, or ice the side of your hip if it bothers you. That can help you get to sleep a little bit better, help decrease the stress of the day, and can be part of a ritual that you have before sleep. If you tell your body, hey, I do the same thing every night, I'm going to bed, and you signal that with some cues like the ice or the herbal tea or whatever it is that you do, that can help you sleep better. And if you sleep better, you can deal with pain better too. Ointments and creams, there's capsaicin cream, which is kind of like a pepper that you put on the skin, stimulates it, can help with pain. Voltaren or topical NSAIDs, anti-inflammatory medications, bandages. There's all kinds of supplements. Glucosamine's one, turmeric's the hot one now, chondroitin. A lot of this stuff doesn't have great evidence, meaning that if you take 1,000 people and you give them all this versus sugar pills, you can't tell a big difference. So does it really work? Well, scientifically not dramatically, but I have tons of people that come in and say, hey, this really worked for me. And so my motto is, if it's inexpensive, if it doesn't cause harm, and it helps you, I don't care if it's in your head, that's great, then do it. If it works, do it. This is the first time in your life where you can say, if it feels good, it can't be wrong. Don't apply that to a lot of parts of your life, but for arthritis, that can be helpful. Non-surgical medications, so the mainstay is the over-the-counter medications. There's 2 main types. There's NSAIDs, or non-steroidal anti-inflammatories. That includes the Aleve, ibuprofen, Motrin, naproxen. And then there's also Tylenol. Acetaminophen is the other name for Tylenol. Those are 2 different categories of medications. It's okay to start with one. It's okay to take one NSAID and one dose of Tylenol at the same time, but you don't want to take more than one NSAID. So you just pick one of those. And then if you have any medical conditions that are important, like liver disease for Tylenol or kidney disease for NSAIDs, you need to be careful. But generally, these are very good medications. They work best as prevent medications rather than rescue medications. So, ouch, my knee hurts, and you go try to fix that with Tylenol, that's going to be a little tougher. I recommend going first with ice and that kind of thing. But if you knew you were going to go hiking, or you knew you were going to be out at the airport or on a trip or something like that, then take the Tylenol ahead of time, and that often will keep you out of trouble. So prevent medications better than rescue medications. Again, you got to be aware of what other medications you take, avoid side effects, and know your health conditions. And if you're on any medication, even over the counter, you should let your primary care physician or provider know. There are prescription NSAIDs. These are things like celecoxib or Celebrex, you may have heard of. Mobic is another one. And they operate just in the same way as the over-the-counter anti-inflammatories. They tend to be single-dose type medications, so they can be a little more convenient. So you take this once a day, whereas you may have to take ibuprofen several times a day. Again, you don't want to take more than one kind of NSAID. So if you're on one of these, you shouldn't be supplementing with the over-the-counter stuff, except for maybe Tylenol. So always want to tell your doctor about your medical conditions before you take any medication regularly, including over-the-counters. We've learned a lot about narcotics. Narcotics work very well for acute pain, meaning pain that is going to last for a week or two. And so that's like surgical pain. You have an incision, you know that's going to get reliably, relatively quickly better. And so narcotics can be helpful for a couple of days, although they have side effects like constipation and nausea. So even in that setting, we're trying to reduce them. Narcotics for chronic pain, or pain that's going to last more than 4 to 6 weeks, so most types of arthritis, is less effective. And that's because the body adapts to these medications and actually can increase the pain response, so that unless you keep going up on the dose of narcotics, pain gets worse control. And so I recommend that people avoid narcotics for chronic pain in general, although everybody's different. They can cause dependence, they can increase pain, decrease pain tolerance, and they can cause hyperalgesia. Injections are another option. The mainstay of injections is corticosteroids. There's different types of corticosteroids. People also call it cortisone. It can reduce inflammation and pain. It doesn't change the cartilage damage, but the cartilage damage can then inflame the knee joint, and so the steroid can act on that. They don't last indefinitely. Some people have a really, really good response, particularly people with mild or moderate arthritis on the x-ray. Other people say, that didn't work all that well for me. You never really know till you try. My other joke for the evening is it's worth a shot. You just try it out. Very rarely there can be complications associated with injections, but not very commonly. There are other types of injections, so people have heard of viscosupplementation or rooster combs. Some of the brand name is Euflexa or Synvisc. There's platelet-rich plasma. There are now stem cell injections. These injections have been compared in head-to-head trials and studies of steroids versus these medications, or even salt water versus these medications, and they don't seem to have any great different effect, but they cost a lot more. And so generally speaking, I avoid these injections and use the simpler ones. Stem cells, usually you're going to have to pay for out of pocket, and they can cost anywhere from $500 to $1,000. Probably not for most people worth it. A few people there may be a role, but not for most people. So when do you turn to surgery? You turn to surgery when non-surgical care has failed. And failed means something different for everybody. For some people, it's they can't go skiing, they can't do the hiking they want to do, and it's limiting their activities of enjoyment. They can't do what they want to do, and so that can be a reason. The most important reason is mobility, is the ability to walk, the ability to get to the grocery store, do your shopping. It's when you're sitting in your car at the parking lot of Albertsons and you're wondering where's that walker, where's that grocery cart that makes it feel so much better to walk around. You know, that's kind of when you're getting there is one of the comparisons I use. But it's different for everybody, and the patient should be the person who drives the decision to do surgery. There are some things where it's not a good idea to delay, but for the most part, if you can tolerate it, it's okay to wait until you're ready and you feel like you need to do it. One quick point is that arthroscopic surgery, that's where we do the little incisions in the camera into the knee joint, it's rarely indicated in the setting of arthritis. We used to do this very commonly. You'd hear of people getting cleanups where you'd go in and you'd shave stuff up, you'd clean up the meniscus, and people seem to do better. But when you do head-to-head trials of people that have physical therapy and non-operative interventions versus arthroscopy, even when they have a degenerative meniscus tear, even when your meniscus is torn, if you've got arthritis, that's the main problem. And so there doesn't seem to be a big difference between those two groups of people. There was even a study where they did sham incisions. So people sign up for this stuff, and they said, we want to help, I guess. So they signed up, and some people got a little poke hole, but no arthroscopic surgery, just the incision. So they couldn't tell whether they'd had a surgery or not. And then those people were compared to people that had had the surgery. And they both went through physical therapy, and they both did the same at 3 months, at 6 months, at 1 year. And so we're learning that we should, generally speaking, avoid this surgery if possible when you have arthritis. Arthroplasty, that's joint replacement. This is a total hip replacement. That's where we remove the ball from the femur where the arthritis was on the ball, and then we resurface the other side on the socket. And then the stem goes down into the femur bone or the thigh bone. That's a total hip replacement. This is a knee replacement. On the one side you have a partial knee, so a partial knee replacement is done when only one part of the knee is involved. So all of this stuff is still good. The arthritis was only over here. You get to maintain your ACL, which is nice. A total knee is done when it involves more than one part of the joint. So again, a partial knee replacement for just, say, the inside part of the joint, which is most common. And we just replace that area. And there's some advantages to partial knee replacement if it's appropriate, and that's a little faster recovery and a little more normal feeling knee compared to a total knee. So what are some of the recent advancements? Well, improved pain control. We've learned about something called multimodal pain control therapy. That means, that's a fancy way of saying give them more than one drug. So give them Tylenol, give them an anti-inflammatory, give a muscle relaxer, give a small amount of narcotic, give a local nerve block and injection. And what that's allowed us to do is decrease the overall amount of medications, especially of narcotics, which then decreases the side effects. So the postoperative nausea and vomiting that people talk about, the fuzziness or the lightheadedness, constipation, that kind of stuff is decreased because we're decreasing the use of narcotics. A big part about pain control and getting people home without complications is mobilization, so getting people walking on the day of surgery. We're now doing hip and knee replacements as outpatient surgeries in many people. It's not for everybody, but it's for a lot of patients, and people get to go home and spend the first night in their bed. They're walking and moving around the first day doing therapy, and that's increased satisfaction in that group of patients. And the nice thing about getting home is we've found that if people get home instead of to a rehab facility, they have fewer complications, fewer readmissions, fewer blood clots, fewer infections. And so those are all some of the big advancements. We've had fewer complications. We have screening programs to help decrease infection risk. We have improved implant materials and designs that have decreased the amount of loosening over 10 and 20 years to where for survivorship of the implants, meaning the implant's still in doing well, is greater than 90% at 20 years. Dislocation risks have been decreased, and blood clot risk has been decreased, and we've also been able to start using less invasive medications. So using aspirin to prevent blood clots for most patients. And that's been a benefit because then you don't have to get your blood checked for Coumadin draws, you have less bleeding risk, and it's the earlier mobilization that's allowed us to do that. And we talked a little bit about improved materials and longevity of implants. So robotics is another one of these innovations. Makoplasty is a brand of robotics. There are other systems out there. I use Makoplasty. That's from a company called Stryker, which also manufactures the implants that I use. And St. Alphonsus has been a leader in robotic surgery. We have the Da Vinci robot for general surgery procedures and urologic procedures, as well as robotics in cardiac care, and now in total hip, total knee, and partial knee. The total knee application has been available for about a year, whereas the other two have been around for several years, and St. Alphonsus has been a leader in that area, getting the robot first back in 2012, and then doing some of the first total knees in Idaho this fall. So that's the robot, and you can see the robot over there. We'll do a little demonstration of how it works in a moment. A lot of what the robot does is it provides us with a three-dimensional personalized plan of your hip or your knee. And so we do a virtual surgery before we're ever in the operating room where we pick the implant orientation, sizes, and customize it to your body. There's a range of implant sizes, and so we can look and say this implant fits you the best. And so we don't have to print a new implant every time, but instead we can say, hey, the 7 works best here, the 6 works best here, and really customize that to you. So how a CT scan works is it's basically multiple low dose of radiation X-rays that get stacked up on top of each other, and that can build then a 3D model. So then we get this model that's created, and the green represents the area where in this example, a partial knee is going to go. And we can pick exactly where to put it. We can move it to the left, move it to the right, move it up or down, rotate it. And all of that is based on intraoperative feedback that we get from your soft tissue. So putting the implants in is just one part of the equation, but putting the implants in so that the ligaments on either side of your knee are perfectly balanced, that makes a big difference in satisfaction after knee replacement. And so now we're able to get some objective data from the robot. And so if I do my plan based on the bones, which is how we start out, and then I show it the soft tissue and it says, hey, it's a little tight here, a little tight there, I can make a 1 degree or a 1 millimeter change to balance out those soft tissues. And that has shown improved results. And so we'll go over some of that improvement in a moment. So again, it's planning. It's also precision. So robotics removes much of my error. We're very good at what we do using cutting blocks and using, it's the saws that we hold, but we're not as accurate as the robot, and we'll go over some data that shows that accuracy. And that accuracy, I think, is long-term going to matter, particularly when you're using precision to balance the ligaments. That's where the big key is balancing that soft tissue. And then there's a safety control, so the robot is able to basically create a force field around the operative site. And if I drift in and out of that, it just turns off. So I'm still doing the operation, but if I move a millimeter to the left or a millimeter too high or too low, the robot turns off and says, hey, you're not doing what you wanted to do. And so that helps protect healthy tissue. So I still perform the surgery. The implants are still put in by me. I still hold the instruments the whole time. I'm not typing instructions on a computer in the corner. And so what the robot does is it makes me stay true to my plan, makes me do exactly what I think I'm doing. So is it better? Because believe it or not, this isn't free. It does add some cost to the procedure. And anytime we add cost to procedure, we want to make sure that there's benefit. That cost is not seen by the patients directly. The insurance companies generally absorb that cost, or the hospital does. But it does get seen by the system. And so it's important that we make sure if we add cost, we're adding quality. So here's some of the research that's available. So there was a study that looked at 1,312 non-robotic partial knee replacements, and then compared that to 284 robotic, so performed with this system, the Mako, and then compared revision rate at 24 months. And they saw a 3.5% revision rate. That means additional surgery versus a 0.4% revision rate. To me, that's very important. So that's 3 people almost out of 100 that didn't have to have an extra surgery in that first 2 years. That's a big, significant cost savings as well, if you think of the cost of a second surgery. So there's some evidence there. Another study compared registry data of partial knee replacements. So in Australia, in Sweden, they keep track of every single implant that goes in. And so if anybody goes to any hospital in Australia or Sweden, that implant's tracked, and so they know how many people need revisions. And they have about a 4.5 to 4.8% in these 2 studies revision rate at 5 years. Whereas another study comparing about 200 total partial knees performed with the robot had a 1.2% revision rate at 5 years. So again, about a 3% difference. That's 3 people out of 100 that didn't need an additional surgery. And revision surgeries can cost as much as $100,000. And so the small incremental cost of using the robot, which is less than $1,000 per case, pretty soon becomes insignificant compared to the savings by preventing revisions in partial knees. What about total knee replacement? Well, one of the studies has shown a reduction in the removal of bone. So on average, we use a little smaller implant on the cup side of the pelvis when we use the robot. That's important because it preserves bone. And so in a very young patient, if there's a risk of an additional surgery in the future, say 30 years down the road, if you have extra bone to deal with as a revision surgeon, about 30% of the surgeries I do are redos of other operations. It's a lot easier to deal with that problem than it is if there's a lot of bone loss. So conserving bone is important. In addition, there's a concept called the safe zone in joint replacement. The safe zone reflects some of the angles that we measure on the x-ray of where the implant goes. And the magic numbers are 40 and 20. It doesn't matter what those numbers are exactly, but we're always aiming for these numbers that we measure on the x-ray. And this is a group of very experienced joint replacement surgeons, so people that only do hip and knee replacement. And it showed that for the most part, they're able to get within that safe zone, which is 40, 20 plus or minus a few degrees. But there's some outliers. And they're kind of all over the place within that safe zone. And so the accuracy is subject to human error. With the robot, that safe zone is much more commonly met. You don't have these big outliers that you had in the other, and it's a tighter bundle. So you put the implant where you intended to put the implant, and that's important. There was another study that compared a surgeon's last 100 hips that he did, and you can see he was fairly accurate, but kind of all over the place. When he did the robot, much more tighter reference. He put the implant where he thought he was putting it, and that translated to important results with him. That surgeon saw a reduction in dislocations, so had he did some anterior approach and some posterior approach, and in both approaches he had dislocations without the robot in that last 100, so the most experienced 100 that he'd done. In his first 100 with the robot, 0 dislocations. So it does seem to translate to a benefit, and that's reduced dislocations. So what about total knee surgery? This is the newer application. Again, nationwide, it's only been done really since March. I've been doing them here since September. And it's really important. So total knee is increasing, and there's a lot of reasons for that. A lot of it is overweight, increases the stresses and forces throughout the knee joint, and so more people are having arthritis show up at younger ages. We spend a lot more time on concrete and hard surfaces. That probably has something to do with it as well. And we're living longer, and so that has something to do with the amount of arthritis. And so we're seeing an increased incidence of joint replacements, expected to be 1 million joint replacements next year. At St. Alphonsus alone, just this hospital here in 2016, we performed over 1,000 total knee replacements, and so that's a big number. So any revision is really, really important for that individual, but also very important to the economics of the health system when we're struggling to pay our bills in this country. And so preventing revisions is really important. So how Mako robotic joint replacement works in the knee is, again, precise planning in all of these planes where we can customize and fit the implant exactly to your anatomy, to where the bone dictates it should be, and then soft tissue feedback in the operating room so that we can then make fine-tune adjustments before we've ever made a cut to the bone to balance that knee and get the ligaments precisely balanced. Ligament balancing has been shown to increase patient satisfaction from historical control averages of about 80%, so 4 out of 5, glad that they did it, happy with their knee replacement. That's really good. That's better than 0 out of 5, which is what non-operative treatment usually gets you. But still, that's 1 out of 5 that's not happy. With good ligament balancing using similar but other systems to get the balance, we've seen increases at 3 years to satisfaction rates in the 90%. So that's really important. Again, if you're that 1 person out of 10 that now gets the smiley face, that's really important for you. And it prevents potentially revisions. The system has not been around long enough for us definitively to say, hey, this prevents revisions, right? Because it's only been around for 9 months. Fortunately, we're using implants that have been around for 10 and 15 years. So we're putting in established implants with a tool that helps us put them in more accurately. And so it's a nice kind of happy medium where you're pushing the edge of technology and getting that benefit, but not exposing people to risk by putting brand new stuff in everybody. So it's much more accurate. This is a cadaver study similar to the one you saw with the safe zone. These are experienced arthroplasty surgeons using their preferred technique of cutting jigs or however they get the implant in. And you can see the error that's present when they do these. Upwards of 6 and 7 degrees, even in the best of hands. Over here, this is the same group of surgeons, the first time they ever used a robot. These were on cadavers. And you can see that the error went down to 1 degree. Across all these measures. So it is definitely more accurate. And again, that accuracy is important, but more important is how that accuracy then allows us to adjust the implants to get good soft tissue balance. And that's the difference. There's been something called navigation around for a long time where we've used computers to get accurate placement of the implants, but the navigation systems did not give us soft tissue feedback. They just said, yeah, you're putting it in where you think you're putting it in. So now we can put it in where we think we're putting it in, but then adjust it and see what that does to the soft tissue, and do that virtually before we actually have to commit to anything. So this is the force field that gets created. This is the safety factor. The saw comes in, I'm still holding it, it's attached to the arm. But if I go outside of this boundary, so blood vessels here protected, ligaments here protected, ligament here protected. If I go outside of that boundary, it just turns off, and I have to reset. So again, one of the other things that we briefly mentioned is this rapid recovery program. I feel that the robots helped us do that by doing more partial knee replacements. People are getting out of the hospital faster. We've had successful discharges with the robot and total knee replacement as well. I think there's less overall trauma to the joint. We're doing tourniquetless surgery now, which helps decrease pain, and all lets us decrease the use of narcotics and get people home sooner and happier. So with that, I'll just emphasize again, this is about doing the things we love. These are some of the things I love to do: hang out with my kids on the blue turf, go in the mountains, try to find some fish every once in a while. And that's what this is all about. It's about you getting back to doing the things that you love to do, and staying active and staying mobile. So we'll do a quick demonstration on the robot here to kind of get you a sense of what it looks like. So this gives us an idea of how we register the robot. So basically, there's a camera system, and it can see these markers, which are calibrated very precisely to within 0.5 millimeter. And so then anytime, and then on a knee, what we do is we put a similar GPS system. We put a temporary pin into the bone. And so if the bone moves, the camera sees the bone move. If the robot moves, the camera sees the robot move, and it can track. And so you know exactly where you are. And so this is kind of how the arm works. So I can still hold whatever instrument I'm using. I have control. It moves around. We lock it in by registering. So kind of locks in. You can follow exactly where it's going. You can see the screen knows where the camera is, knows where the instrument is. We go back up here. You get some feedback. Drawing this perfect circle then gives us, again, a tolerance of about 0.5 millimeter. And so then now I can move this around, and the camera tracks everything. So then what we do is we take our plan. So this is a partial knee, and you can see we've planned this based on the bone. But what we're going to do is we would run the knee through some motions, and the camera's going to watch the knee now and say, when you go at 90 degrees of flexion, there's a little opening of the medial part of the knee, or the inside part of the knee. When you go all the way to straight, it closes down a little bit, and then we get a little graph. Can you show a graph at all, or an example of a graph? Probably not. And so then that graph will say, hey, it's tight here or loose here, and I can then say, hey, Matt, I want to put this implant down 1 millimeter. So then Matt can move the plan and shift that implant down 1 millimeter. And then we prepare the bone, we know it's going to be accurate. So you can make those fine-tuned adjustments based on the soft tissue, which is very, very helpful. All right. So that's kind of how the robot works. There are some things online. If you YouTube, you can watch it in a little more detail. Not everybody's excited about that, but MAKO is the name brand, and everything's on YouTube. So it's out there, but there's some more demonstrations. And there's also a video available where I kind of take it through what's called a sawbones example, which is a model instead of the real deal.